So today you'll be hi Mani. So welcome to the nephrology from the next student. So today we'll be discussing about how to approach a patient with elevated RFT. So it's a very common scenario that a patient might come to us with an elevated deranged RFT. So what do you mean by RFT is nothing but the usual serum urea creatinine. So a patient presents to us with an elevated urea creatinine. So how should we approach this patient? So first of all, serum creatinine by itself doesn't make any sense at all. So we have to calculate eGFR. So we have to calculate effective glomerular filtration rate. So what is actually how do we assess the function of the nephron? So how do we assess the function of the kidney? So function of the kidney is nothing but single nephron GFR into total number of nephrons. Okay, single nephron GFR into total number of nephrons. So how do we calculate eGFR in a patient? So the age-old Cockcroft-Gault formula, Cockcroft-Gault formula, Cockcroft-Gault formula, it is nothing but 140 minus H into body weight divided by serum creatinine into 72. Okay, that is in case of males. In case of females, you have to multiply it by 0.85. So, what are the pitfalls in this formula? So the major pitfall is the overemphasis on age. Okay, so the overemphasis of age in this formula. So basically, what happens is if a patient if a patient of consider a male patient of 90 and a male patient of 30. So we will calculate how much will be the serum eGFR based on Cockcroft formula. So in case of a patient with age 90, so it will be 50, and we will consider both the body weight as 50. Okay, into 50 divided by serum create 1 into 70. For ease of calculation, we'll take it as 70. Okay, so how will it be? So 250 by 7, 250 by 7 uh, will be 3, 35. So at the age of for an age, male patient who is age 90, he will, with the serum creatinine of 1, he will be having only GFR of 35 as per the Cockcroft formula. So for a patient, with the same creat for a patient of age 30, how will it be? So basically, it will be like 140 minus 30, 110 into body 50 divided by serum creat. So basically 550 divided by 7. 550 divided by 7 is 7, approximately 80. It comes to about approximately 80. Exactly 550 by 7 is 749, 49, 79, approximately it will come about it's approximately 80. Okay, so this is the issue with Cockcroft formula, the overemphasis on age. So with the same creatinine, the male patient of my age 90 will be having 35, and a patient of 30 will be having, of the age 30-year-old will be having 80. So overemphasis on age is one issue. So the next issue is serum creatinine base is actually dependent on the body mass of the patient. So basically, a bulky patient, a patient who who is more physically active, will be having more amount of baseline serum creatinine than a normal person. So that is also another issue. Okay, so body mass. So because of all these things, we no longer use Cockcroft-Gault formula. It's not like we no longer use, but it's always a very good bedside analysis of. I mean, it can be easily done bedside. If you're good at mathematics, you can do it in mind. So it's not like it's an age-old thing. We still use it. We always use it because it's very. I mean, it's very, especially in a low resource setting, and it will be very nice. I mean, it's a very useful hand tool. Okay. So now we'll go to the more precise GFR calculation by MDRD and CKD EPA. So these can be actually, we use online calculators for using these formulas, out of which the most important one is CKD EPA. Okay, the most important one is CKD because it's the more precise one. It will take into account serum creatinine, serum cystatin C. Okay, so it's a more reliable formula than Cockcroft-Gault formula. So, having discussed about EGFR and how to calculate, so we will come to, I mean, how do we approach this patient? So, first of all, we told about a male patient who's of 30-year-old male, who's coming to our OPD with a serum creatinine of 1 and his this thing is EGFR is 80. Suppose suppose if he comes with an creatinine of 2, okay, 30-year-old male comes with an elevated creatinine of 2. How do we approach? How do we approach? Okay, so his EGFR will be coming about 40 millimeter per minute per 1.73 meter square. Okay, as per the Cockcroft-Gault, obviously as per the Cockcroft-Gault formula. So now, how will we approach this patient? So first of all, before approaching any renal disease, you should have 3 investigation at hand. So what are all this? Two and 3 investigations at hand. So what are all this? One, we already have the RFT serum electrolytes, then USG abdomen plus pelvis, and urine routine with the deposits. So having looked at the RFT value with a creat of 2, we calculated the GFR which is about 40. How will we approach this patient? So ultrasound abdomen plus pelvis, USG abdomen plus pelvis. So what is the significance? So we look at the kidney size of this patient. So the size of the kidney can be less than 8 centimeter, 8 to 10 centimeter, and more than 10 centimeter. Okay. So less than 8 centimeter is nothing but a contracted kidney which is equal to CKD. CKD. Okay. Less than 8 centimeter contracted kidney seen in CKD. So why is it contracted? So what is CKD? Pathologically it is nothing but interstitial fibrosis plus tubular atrophy plus glomerular nephritis. So basically the entire part of the nephron, the glomerular part undergoes nephritis, the tubular part undergoes atrophy, and the in between interstitium get fibrosis. So that is nothing but CKD. So in ultrasound you will be seeing a kidney size of less than 8 centimeter. So if the kidney size is 8 to 10 centimeter, what will you look for? We will look for the CMD, corticomedullary differentiation, if it is maintained or not maintained. If it is maintained, well and good. If it is not maintained, again it is CKD. Okay, and you can classify the stage based on EGFR with the KDGO. So greater than 10 centimeter, we again, even if the size is normal, you have to look for CMD. If it is maintained, well and good. If it is not maintained, again CKD. So there are, like, you can actually come out with nearly 3 differentials if you have a greater than 10 size in kidney and the CMD is not maintained. CKD with a large kidney. What are the differences? DKD, diabetic kidney disease, diabetic kidney disease or diabetic nephropathy. Amyloidosis, then HIVAN, HIV associated nephropathy. HIVAN, okay. So having looked at the ultrasound, we will be able to, and one of the other big use of ultrasound is you can also identify post-renal pathologies, post-renal or obstructive uropathy pathologies. Okay, post-renal pathologies can also be identified with ultrasound. So a 20-year-old male comes to a 30-year-old male comes to you with an creatinine of 2. You calculate the eGFR as 40 ml per minute plus 1.73 meters square, and you look at the ultrasound. The ultrasound is normal. So you have ruled out. What? You have ruled out the CKD, and you have also ruled out post-renal. So what are the remaining things? What is left? So you ruled. So we'll take a write it out here. So 30-year-old male, GFR 40 per minute plus 1.73 meters square. USD normal, so not CKD, not post-renal. So we all know the three renal pathologies. It can be pre-renal, renal, or post-renal. So what are the remaining? It can either be pre-renal or renal. So how will we differentiate? And which other investigation you look into? As I already said, now you have to look into the urine routine of this patient. First, what you have to look for? First, you have to look for any cast in the urine. So, sorry, first you have to look for all this physical. First, you have to look for the physical appearance of the urine. A concentrated, turbid, a concentrated thick yellow can be suggestive of a prerenal pathology, because in prerenal the urine osmolality is very high because it's a very concentrated urine you will be having in a prerenal pathology. So what is a prerenal pathology? In hypovolemia, there will be reduced renal perfusion, which will result in the kidney, which will result in the nephron concentrating the urine, uh, which will be having a very high dark colored urine in case of a prerenal pathology. Okay, so concentrated urine can be suggestive of prerenal pathology. Turbid urine can be suggestive of an infective pathology. So then pH. So basically, we should secrete an acidic urine. Okay. So in case of infections, it can be alkaline. Very well, it can be alkaline. But if it is if you are suspecting some acidosis and if the patient's urine is alkaline, pH is normal. pH is about 5. So if it is more than 5.5, you call it as an alkaline urine. If it is less than 5.5, it is an acidic urine. So if it is more than 5.5, it means there is no actual acidification of the urine. So actually, before saying anything about urine routine, we should know which sample to be given for urine routine. It's always the sample, second sample, sample whose midstream. We have to collect the midstream of the second sample of the patient. Okay, it's not the first early morning sample because the sediments, overnight stagnation will affect our results. So we have to get the second sample to the midstream sample in case of urine routine. So if it is alkaline, so basically before checking the pH, actually you have to put a drop of coconut oil and send to the lab, and pH has to be checked immediately, because the acidic urine can very well be turned into an alkaline urine when it gets exposed to atmosphere. So you have to check it as soon as you can with a drop of coconut oil on the top of the urine sample collected. So alkaline urine and acidic urine. If it is if even after all this, if the urine is alkaline, you have to suspect that the acidification of the urine is impaired. So what is responsible for the acidification of urine? Distal tubule. Distal tubule is responsible for the acidification of urine. If distal tubule is impaired, definitely we'll be having alkaline urine. Okay. So that's when distal RTA or type 1 RTA will be having alkaline urine. That is how you will differentiate proximal RTA from one of the methods you will differentiate proximal RTA from distal RTA. Distal tubule impaired. So now we will be looking for any cast in the urine. Water cast, actually, basically the Tom Horsfall protein getting mixed with RBC, getting mixed with WBC will produce cast. The Tom Horsfall protein alone will be causing hyaline cast, which is very well normal in a patient. Hyaline cast normal in a patient. So what are all the other casts? It can be granular cast, seen in AKA, and can be granular cast seen in AKA. It can be RBC cast seen in nephritis, and WBC cast seen in infection. What else can be? Yeah. We can take a look into the pictures of this actually. So this is Goldman's. It's a very good book actually. So this is the hyaline cast. This is the oxalate cast. This is the erythrocyte cast. This one is This is the erythrocyte cast. This is the normal hyaline cast. Okay. So now we will also have to look into the, if there are RBCs present in the urine. If you say so, how do you approach a dark colored urine? We told you physical appearance, concentrated urine. There is a dark colored urine. Concentrated dark colored urine. How will you approach? So first, if it's a dark colored urine, you have to rule out hematuria. So if it is frank blood, it's understandable. Even if it's frank blood, first you have to centrifuge. If you are able to obtain a clear supernatant, it is RBCs, clear supernatant. It's RBCs that is present in the urine. We have to look for most in. So I will look into that. So RBCs in the urine. If you are not able to get a clear supernatant, it is mostly due to, it can either be due to hemoglobin or it can be due to myoglobin. So you keep the, you can actually separate it using ammonium sulfate, or you can just keep it, you can keep it for a while. If it is settling on its own, it is hemoglobin. If it's not settling on its own, it's myoglobin. You get a dark colored urine sample, you centrifuge it. If it is a clear supernatant, it's RBC. So if it is RBC, you have to look into the microscopy. there is something called the 40-4-1 rule, 40-5-1 rule. So if in the microscopy, if you're having, if in the microscopy, if you're having 40, the 45 rule, so it can be 40% dysmorphic RBC plus 5% acanthocytes and 1% 40% dysmorphic RBC, 5% acanthocytes, and even 1%, even one, sorry, one, not 1%, it is one RBC cast. This implies glomerular hematuria. It means the pathology is a renal pathology with the glomerulus involved. Okay,